Hello everybody, and thanks for giving me an opportunity to present our study, the topic of which is incidence of tubercular pericardial effusion in pediatric patients in asymptomatic post-COVID infection. So in children, up to 25% of the cases of tuberculosis are extrapulmonary, and tubercular pericardial effusion, though is a rare manifestation of extrapulmonary tuberculosis, is one of the most common causes of pericardial effusion in high burden TB settings. This study is retrospective descriptive study which includes children less than 18 years old diagnosed with either confirmed or probable TB at a tertiary care referral center in East Delhi and surrounding NCR between June 2020 and July 2021. The study children were referred to a pediatric cardiologist for cardiomegaly and chest pain in OPD or for fever, tachycardia and cardiac enlargement on X-ray in IPD. We described confirmed TB as diagnosed by echocardiography and CT, a positive culture result for Mycobacterium tuberculosis from any side. Probable TB was described as defined as a culture negative or unavailable for M. tuberculosis. Pericardial effusion was described as above. A clinical TB diagnosis based on chronic symptoms or signs, contact with an infectious TB source, and most importantly, a positive tuberculin test result. The results were as follows. There were 10 children with tubercular pericardial effusion which was included in the study. 5 were male and 5 were female. This is purely coincidental. Median age was 13 years and interquartile range was 13 to 18 years. Of these children, 3 had symptoms suggestive of TB pericarditis, that is difficulty in breathing, jugular venous distension, etc. 1 had presentation features of constrictive pericarditis and heart failure, and 1 had an isolated pericardial effusion. 2 had features of pericardial effusion associated with lung collapse. So all the children had RT-PCR for COVID negative COVID negative and did not give history of such either except in one girl whose family members had COVID and she also had symptoms but nothing major. But COVID antibodies were positive for nearly all the children. All the children received susceptibility appropriate anti-tuberculosis treatment. Duration was 9 months and some are still ongoing. Steroids were started in all the children and this was continued for 4 to 6 weeks. One child was treated for cardiac failure with diuretics and eventually had to go pericardiectomy. 4 children with large pericardial effusion had among the, 2 of them had to go for pericardiocentesis and the rest of them were all treated medically. So now coming to the discussion, in a statement, Ministry of Health and Family Welfare said that there had been some media reports of alleging that there is a sudden rise in the cases of TB which was noticed among the patients who were infected with COVID-19 recently. Coming to TB and COVID, the dual morbidity of TB and COVID can be further highlighted through the fact that both the diseases are known to be infectious and primarily attack the lung, presenting similar symptoms of cough, fever, and difficulty in breathing, although TB has a longer incubation period and a slower onset of disease. Now there are two postulates to the this theory. So one was presented as a research paper which said potential impact of COVID-19 pandemic on tubercular epidemic. This was a modeling analysis which adapted mathematical models of TB transmission in 3 high burden countries of India, Kenya and Ukraine to see disruption in TB care cascade. They predicted the impact of these disruption on TB incidence of mortality over next 5 years. And in India model, they had 3 specific disruptions affecting the most incidence and mortality. First is incidence of initial patient delay before the presenting to the provider. Second is the probability of diagnosis per visit to a provider, and the last is drop in the treatment initiation. The second postulate which can be more likely is to do with latent TB. So not everyone exposed to the bacteria Mycobacterium tuberculosis gets infected immediately. While the infection manifests as active TB in some, in few, the bacteria can live long in the body without ever causing active disease, a condition known as latent TB. Latent TB can get activated into active TB when the body's immune system is weak. And the same is applicable post COVID scenario when an individual may develop decreased immunity to the virus itself or due to treatment, especially in immune suppressant like steroids. SARS-CoV infection can make an individual more susceptible to developing active TB disease, as TB is an opportunist infection like black fungus. There is a news from the Kerala which was published in June 2021, a COVID trigger for tuberculosis. Now, this has said that TB screening mandatory for all post-COVID cases with cases going on. These cases are mostly adults. So it had asked the question that whether TB COVID-19 is leading to a flare of tuberculosis in the state, when there is no conclusive evidence yet to establish that COVID-19 can directly trigger an increase in tuberculosis. TB cases have been steadily going up in the states, especially post-COVID states. And pulmonologist in Kerala is now reporting new TB infection among persons with 4 to 6 weeks of recovering from COVID-19. With 10 such cases already reported, the health department is now issued an advisory that routine TB screening to be made mandatory in all post-COVID clinics. So what we have learned from the Kerala chapter is the prevalence of latent TB is estimated to be 20%. 10 cases of TB detected within 4 to 6 weeks after treatment for COVID-19 are just the tip of icebergs and early pointers that there should be many more cases in the community that need investigation. Most of these cases had diabetes and had been treated with steroids as a part of COVID treatment. So further studies are needed to ascertain if COVID actually precipitated TB in these patients. So the take home message is the new government advisory says it is important that patients with persistent respiratory symptoms immediately after recovering from COVID should be evaluated for TB. It is through a systematic screening in post-COVID clinics. TB screening should be done in routine practice in all COVID clinics, and health workers have also been asked to check for TB symptoms in patients they meet in fields and who are recovering from COVID. Thank you for the patient hearing, and please stay safe.